Good evening, everybody. Thanks so much for coming. I am honored to be able to introduce our speaker this evening. Some of you have heard me talk about him in the past. Dr. Stephen Pantilat is a palliative care physician and a hospitalist, and is an internationally recognized expert in both hospital medicine and palliative care. Dr. Pantilat is the director of the UCSF Palliative Care Leadership Center. They go around the country and teach people how to build their programs. He's also the director of the Palliative Care Quality Network that we are a part of now. We are submitting our data to that network, so it's very exciting. It allows us to compare what we're doing to what others are doing. He has helped in collaboration of over 85 palliative care teams focusing on improving the quality of care for seriously ill people. And you know that with hospice we talk differently, but with seriously ill people, maybe you just found out today that there's something going on and now you're trying to figure out, now what do I do? So we're going to hear a lot about that. His new book, as you see in front of you, some of you, is Life After the Diagnosis, Expert Advice on Living Well with Serious Illness for Patients and Caregivers. And some of you I've shared this book with, so I'm happy that you are here this evening to hear more about it and ask questions and really dig down deep into it. Dr. Pantilat will be available afterward for the book signing. And as Deshay said, there's a small quantity of books outside for you to purchase, and Dr. Pantilat will sign those for you. So I am honored and pleased to be able to introduce Dr. Stephen Z. Pantilat right now.
Great. Thank you, Karen. Thank you so much. Thank you. It's really a pleasure to be here. All right, so you're on a plane flying at 36,000 feet. You're sitting back, reading a book, sipping a drink, when suddenly the plane drops 10,000 feet and you look out the window and there's an engine on fire. That's what it's like when you get a serious illness diagnosis. When the doctor says you have cancer. The test shows that it's ALS. You have dementia. You're in a panic, and you feel like you're going to die. And while it feels like you're going to die, it turns out there's a lot we can do in medicine to right the plane and get it to fly smoothly. Now, it is true that you may not be able to stay aloft quite as long, and the destination may differ. But no matter how serious the medical news, it's always possible to get the plane to fly smoothly and to get your life back in control. Even in the midst of chaos, there is hope. Now, when we talk about serious illness, there's a lot of bad news, but there's also good news. So let's talk about that for a moment, and let's start. Okay, let's start with the good news. Here it is. The good news is that there's never been a better time to be alive if what you want is to be alive. So you can see here that after being flat for all of human history, human lifespan has increased dramatically over the last 100 years. So if you go back to the year 1900, we lived on average to be 50 years old, 50. And today in the United States, we live on average to be near 80. And that is a tremendous increase. That's really good news. So what's the bad news? Well, the bad news is that over this exact same period of time, the death rate has remained remarkably stable at exactly 100%. Now, of course, you didn't need me to tell you that. But what's less obvious from this slide is that while it is true that on average we will live longer, it is also true that we are likely to spend part of that time, years or decades, with serious illness, like heart failure, like chronic lung disease, Parkinson's disease. And when that happens, it's like the plane is plummeting to the ground. And the tendency for people with serious illness and their loved ones, even doctors and nurses, is to turn away from what's really going on, to not face the seriousness of the news because it's just too hard to face. We don't want to make the person who is sick feel bad or sad, and therefore we just turn away from what's really going on. The challenge is that when we do that, we leave that person who is sick isolated. And in trying to be helpful, we can sometimes make things worse. And in fact, in our society, we have myths that relate to our understanding of serious illness that often get in the way of how we can get good care in the face of serious illness. And I want to talk to you about 3 myths and then correct the myths to tell you the truth and how that might contribute to getting better care in the face of serious illness. And the first myth is this, is that somehow you have to choose between quality and quantity of life. And that goes something like this. Well, if you want quantity of life, if you want to live as long as possible, you have to accept all the treatments that the doctors and nurses offer. So you have to get chemotherapy, enroll in a clinical trial, sign up for a transplant, have surgery. That's how you live long. And of course, we know that those things can be uncomfortable, so you might have to sacrifice a little bit of quality of life in order to live longer. Or you can choose quality of life as the most important thing and not have all those treatments, but then you're going to not live quite as long. Turns out that's a myth. The truth is that you can have both. And what's true is that palliative care can help you get both. If there's one study that you need to know about palliative care, I'm going to share this one study. There are many studies about palliative care, but I'm going to share with you the one study that you need to know. This study was conducted at Massachusetts General Hospital and published in the New England Journal of Medicine in 2010. In this study, they enrolled 151 people with a new diagnosis of metastatic lung cancer, which is a very serious illness. At the time this study was done, now 9 years ago, people with a new diagnosis of metastatic lung cancer lived on average for only 9 months with treatment. So it's a very serious diagnosis. Everyone in the study received state-of-the-art chemotherapy at Massachusetts General Hospital at Harvard, which is apparently very good. I like to say it's not UCSF, but apparently it's good. Half the people in the study were then randomly assigned to receive palliative care in addition to their standard state-of-the-art chemotherapy. And what did they find? Basically, they found everything good that we want to have happen to patients happened to the people who received palliative care in addition to their chemotherapy, which is to say, they had better quality of life. They had a better mood. They had less pain, less shortness of breath. They were less likely to get invasive care at the very end of life, which is to say they were less likely to be in an ICU or to receive CPR at the very end of life. Better health for loved ones. And that's not from this study, but from many other palliative care studies. And from studies of hospice, we know that if a person with serious illness receives palliative care or hospice care, their loved one has an easier time in grief. They're less likely to have complicated grief. And there's studies from hospice that show that if you receive hospice care near the end of your life, your spouse is less likely to die in the 18 months after you die. Think about that for a moment. Care that's provided to a patient not only improves care of the patient, but also improves the health of their loved one. They have greater satisfaction with care, so they like the care that they're receiving better, and they live just as long and maybe longer. In this study, with people with lung cancer, those who received palliative care in addition to their chemotherapy lived longer by 3 months, a year compared to 9 months. So this idea that somehow we have to choose between living long and living well really is a myth. And the idea should be that if you have a serious illness, you should get palliative care. I like to say that if it was a drug, everyone would get it, right? Because we give it to people with lung cancer, and then someone would say, well, I bet that's going to work in breast cancer and colon cancer too, and why don't we give it to those people with dementia and heart failure? But it's more complicated than that. It's a team of nurses, social workers, chaplains, doctors working together to provide care for people with serious illness and their loved ones. So I've been talking a little bit about palliative care, but I really haven't defined it for you. I bet if we went around the room and asked the palliative care folks about it, we'd get maybe many different definitions, but I want to share one with you that I like. It's the one that I've been using now. There are many. The World Health Organization has one. The Center to Advance Palliative Care has one. There have been other published definitions. This is the one that I like. And it says that palliative care is medical care focused on improving quality of life for people with serious illness. Simple, direct, to the point. Two things that are really important here. One, it's for people with serious illness. There's nothing about the end of life or about dying. If there's one message that I would leave with you today, it's that palliative care has an important role to play in the care of people with serious illness. It's not about dying. And what are serious illnesses? Certainly cancer, Parkinson's disease, dementia, ALS, heart failure, chronic lung disease. The focus is on improving quality of life. How can you live well with your serious illness? Abraham Lincoln said, it's not the years in your life, but the life in your years that matters. And whether we measure life in years, or sometimes in months, or even weeks, the question is, how can we help you live as well as possible for as long as possible? Which is what I say to my patients when I see them. I've gotten into the habit now in our clinic that when I meet a new patient, I will ask them, one, do you know why you're here? Which is often an interesting conversation. And then I ask them what they understand about palliative care. And I had one patient recently, I said, what do you understand about palliative care? And she said, oh, your job is to take people from being sick to dead. I said, oh, that's amazing. I need to write that down, which I did. And I said, okay, how about this? Palliative care, and I gave her this definition. She's like, oh, that's better. I like that better. I like it because it's very direct, it's very simple, and it really speaks to what is really the most important issue, which is how can we help you have the best possible quality of life? And we'll talk more a little bit about what that means and how we might actually get to that idea of what's really most important to people. And when we think about who's appropriate for palliative care, I like to think about three things. One, do you have a serious illness? And here's a list of serious illness. This is not a difficult list to put together. Being admitted to the hospital or emergency department visits, 2 or more of those in a year, just marks people whose heart failure or whose COPD is just more serious. Not everyone with a new diagnosis of heart failure needs to see a palliative care team. But as you get sicker and start coming to the hospital or to the emergency department, that's certainly a sign that you're getting sicker. The other thing we think about is what we call utilization. It turns out if you come to the hospital a lot, that's not good. That's just a bad sign. And so it's not, the problem isn't that you're using healthcare. The problem is that when you're sick enough to need to be hospitalized a lot, that's a bad sign about your health. And finally, function. Turns out that if we want to understand how sick people are, what we are able to do in our lives is a really important predictor of how sick we are. And so, can you bathe yourself? Can you feed yourself? Can you get out of bed by yourself? Can you get out of the house? Can you cook? All these things that many of us take for granted every day are the kinds of abilities that we can lose as we get sicker. And as we lose those abilities, that ability to function in our lives, that's associated with getting sicker and is an indication that not only someone is getting sicker, but that they might be appropriate for palliative care. And then one of the things that one of my colleagues has written about that's really helpful is to ask yourself this question. I share this with doctors, but I think any of us can ask this question. Would I be surprised if this patient died in the next year? And we don't always think about it this way, but it turns out this is a pretty good question for figuring out who needs palliative care. Would I be surprised? This is not a very good question for figuring out who's going to die. Like, we're actually not very good at that, at predicting that. But it is a good question for figuring out who is sick. So that's a question that we can ask. So the myth is that you have to choose between quality and quantity. The truth is that you can get both, and that palliative care and hospice can help you get both. So what's the next myth? The next myth is that somehow talking about what's really going on is going to destroy hope. Right? So don't talk about what's really going on. So a couple weeks ago, I was in the hospital, and I was taking care of Grace. Grace is 61 years old, and she had very advanced lung cancer, admitted to the hospital with an infection and with pain. And I was walking down the hall, and I was about to go into Grace's room, and her daughter stopped me. And she said, "Doctor, whatever you do, don't tell my mom she has cancer." And I could really feel the care and love that motivated that request. And this really came from a good place. And then I thought to myself, wait a minute, what does your mom think she has? She's actually been coming to the UCSF Cancer Center for 3 years. And if you've ever been there, there's this huge sign on the outside of the building that says UCSF Cancer Center. And she reads. And I get it. I understand. It's out of love that we want to avoid talking about what's really going on. Right? We don't want to make the person we care about sad or take away hope. And I understand the worry that talking about what's really going on will destroy hope. But in my experience, it doesn't work that way. In my experience, talking about hope encourages it. Because hope is an essential, fundamental part of the human experience. Hope is durable and powerful and persistent, even in the darkest of times. Hope is a positive emotion, like joy and awe and gratitude and love. It makes us feel better to talk about it. In fact, hope is the antidote to sorrow and despair. And so talking about what we hope for can actually be a source of encouragement and can actually, rather than make us feel sad, can make us feel better. And so if we really want to express love and caring, we have to find the courage to talk about hope and to face reality about what's really going on. Because people who are sick know what's going on. And naming it is often a great relief for patients because they get it. The challenge, of course, is that we in healthcare, we sometimes make things worse because we don't see what's really going on. So Helen was an 85-year-old woman with very advanced dementia. And she was living at home with her daughter, receiving hospice care. So one morning, Helen's daughter comes into her room and finds that she's breathing 4 times a minute and she's moaning. And Helen is dying. And Helen's daughter panics. And instead of calling hospice, she calls 911. And the paramedics come and they whisk Helen off to the emergency department. And in the emergency department, when Helen's daughter shows up, the doctor pulls her aside. And he asks her this question: would you like us to do everything possible for your mom? So maybe you've heard that. People are laughing. Maybe you've heard this question before. Today. Great. Now, what do you think Helen's daughter said? Yes. Right? I mean, can you imagine? You bring your mom to the hospital. And the doctor says, would you like us to do everything possible for your mom? And you say, you know, for my mom, half would be plenty. You know, don't knock yourself out. My mom's a quitter. No mom is a quitter. Terrible question. Terrible question. Better to ask, how are you hoping we could help? Now, so of course, when the doctor asked this question of Helen's daughter, she said yes. And so the doctor got on the phone, called the intensive care unit team, called the medical team, come down and admit Helen to the hospital. And we know what would happen, right? She'd get big IVs in her neck, IV fluids, antibiotics, x-rays. She probably would get a tube down her throat, on a ventilator, maybe dialysis. Turns out one of our colleagues, who's a palliative care doctor, happened to be on call for medicine that day. And he heard the story and immediately ran down to the emergency department, beat the ICU team, because sometimes the palliative care team has to be fast. He pulled Helen's daughter aside and he asked, how were you hoping we could help? And Helen's daughter picked up a shopping bag. And she said, we brought new clothes. We need to dress her in new clothes for her journey to the next life. And the doctor said, well, that's really important. We should do that right here in the emergency department. And she's very uncomfortable, so we're going to give her some medicine so she can be more comfortable. And then we'll move her upstairs to a quiet room where all of your family can be with her. And Helen's daughter said, yes, thank you. And that's what happened. Because we had the courage to see what was really going on, to name it, and to ask the right question about hope. And it was in asking the question about hope that we understood what really was important to Helen and to her family, and helped us do that. Talking about hope is so important that I call it the golden question. The golden question goes something like this. When you think about the future, what do you hope for? And I think the flip side of that I like to ask is, when you think about what lies ahead, what worries you the most? These are opposite sides of the same coin. Right? What you hope for, those are the things you want to have happen. The things you worry about are the things you want to avoid. Mary was a 72-year-old woman with very advanced interstitial lung disease, which is a chronic, progressive, incurable scarring of the lung. Virtually everyone with this illness will develop shortness of breath and will die typically within a couple of years of diagnosis. Mary was admitted to our hospital to the intensive care unit with a pneumonia that had worsened her breathing and from which she was not going to recover. She was on such high levels of oxygen, on high-flow oxygen, that we could only provide it in the intensive care unit. And she was not doing very well. One morning on rounds, we were there, the palliative care team with the ICU team. I said, I think we have to go in and talk to Mary about what she hopes for. And the ICU team looked at me like I was crazy. I said, Steve, have you seen her? She's really sick. I mean, what could she possibly hope for? There is no hope. But we went in, and we were talking. I said, Mary, when you think about the future, what do you hope for? And Mary looked up and she said, I hope to see my daughter get married. I said, well, that's really important. Tell us about that. She said, well, it's in 10 months in the Napa Valley. And I thought, I don't see it. I don't see that she's going to live that long. And even if she did, I don't see any way that she's going to get out of our ICU and make it to that wedding. And so we talked about it as a team, and then we talked with Mary and with her daughter. And her daughter said, well, that's really important to me too. I'm going to get married right here in the ICU. And sure enough, 3 days later, Mary's daughter comes into the ICU in this beautiful white wedding gown. And her fiancé is in a tuxedo. They put a corsage on Mary's hospital gown. Our chaplain officiated at the wedding. There was family and friends and all the nurses and the doctors and the respiratory therapists not a dry eye in the ICU. And it was beautiful. Mary got to experience the thing she most hoped for because we had the courage to ask what she hoped for. And when she told us what she hoped for, we had the courage to say, if that's important, we need to do that now. Right? Because it's easy in that situation to say, oh, I hope so too. Right? And what would Mary think? Right? She thinks she's going to make it, when I'm thinking the exact opposite. And I would submit to you that if Mary thinks she's going to make it and I think she's not going to make it, she doesn't have hope. She has false hope. And that ultimately false hope is no hope because it is not based in reality. And you might be thinking, oh, come on, what's the harm of a little bit of false hope? I mean, look at how sick she was. Let her have a little false hope. The harm is that she squanders her time, that she pursues and accepts treatment that may be more likely to harm than to help. And ultimately, the harm is that she loses the opportunity to do the things that are really important. We have to be in the realistic hope business, in the true hope business. Because while we may not be able to achieve all our hopes in the face of serious illness, there are many hopes that we can achieve if we just ask about it. Visiting our hometown, finishing a book, getting a degree, making a quilt for our as-yet-to-be-born grandchild. And to know that we can experience joy and love and gratitude and awe, even in the face of serious illness. So what else is important to people who are facing the end of life? Well, there was a survey of Californians done by the California Healthcare Foundation. And what did they find? The most important issues at the end of life, making sure my family is not burdened financially by my care was the single most important concern that people had. Which is an important concern because health care costs are the #1 cause of personal bankruptcy in the United States. So not working, taking time off to care for your loved ones, and the cost of the care itself are a huge financial burden. Being comfortable and without pain. Being at peace spiritually. Making sure my family is not burdened by tough decisions about my care. How do you make sure of that? Advance directive, right? If you don't have one, your family will be burdened by decisions about your care. They will, because that's where we turn to make those decisions. One of the most important things we do in the palliative care clinic and on the palliative care service is talk to people about their preferences and wishes and document them so that they're clear. Interestingly, living as long as possible was only endorsed by 36% of people, which is not to say that that's not important, but it is not the most important thing to the most people. But if you look at our healthcare system, you might think it's the only thing that matters. And so we have to ask people what is in fact most important and what you hope for so that we can understand it. And we have to make sure that when we ask the question, we answer it in the right way. So I told you a couple things we should say, like the golden questions. I want to share one thing we shouldn't say, which is this: there's nothing more we can do, which maybe you hear around healthcare institutions. I'm sorry, Mr. Jones, nothing more we can do. Now, I think I know what we mean when we say that. There's nothing more we can do to make your illness go away, to cure you. But that's not what that says. And the problem is it's simply not true because there's always more that we can do, and it feels like abandonment. Hey, there's nothing more to do. I don't need to see you anymore. At a point in someone's life when they really need ongoing care and connection to their doctors and nurses and social workers and chaplains. And so I teach my students, do not say this. We don't say this. Instead, we say, I wish there was something we could do to make your heart stronger, to make your cancer go away, to make your lungs better. I wish. I wish is a very powerful statement. because it puts you on the same side as the patient. Right? The patient says, well, there must be something you can do for my cancer. And you say, well, there isn't. Well, there must be, but there isn't. As soon as you say, I wish, you're on the same side. What I like about it is that it's true. I do wish I could make your cancer go away. But there are limits to medicine and biology that we all have to deal with. So let's think about what we can do to help you feel better. I wish. To the parents in the crowd, I would say this is a great parental tool. So this was a few years ago when my son was 5, and one Saturday morning he wakes up, he says, Daddy, can we go to Legoland? That sounds like fun, but we live in San Francisco, right? And so the nearest Legoland is in San Diego. And the answer is, in fact, no. You cannot wake up in the morning in San Francisco and end up in Legoland. But I thought, oh, I'm a smart guy. I said, oh, honey, I wish we could go to Legoland, but Legoland is far. So we have to plan it for another day. Maybe we'll do something else fun. He was like, oh, okay. I thought, okay. One for Daddy. But I do have to warn you not to try this on your spouse or partner, because I think that is a loser. One night, it was like one of these cold, rainy nights in San Francisco. My wife's like, oh, Steve, the garbage needs to go out. I'm like, oh, I'll try that. I'm like, oh, honey, I wish I could take out the garbage, but, it's really cold and rainy. And my wife's like, just go take out the garbage. So you do have to be cautious, but it is a very, very useful communication tool. All right, last myth. The last myth is that somehow the goal is to have a good death. You probably heard this a lot. Maybe you've been to a death cafe. We're going to make death good. We want to give you a good death. Right? We're going to make death a good thing. Go to death cafe, talk about the kind of death you want. I've been around a lot of death in my job. I've yet to see one that's good. Mostly they're lousy. And that's not to say because people are suffering, but just because it's sad. And talking about a good death ignores the fact that death is sad, and it is filled with grief and loss. Our goal should be to help people die peacefully and comfortably and with dignity, and we can do that. But that still doesn't make death good. And I worry that in the language of a good death and talking about a good death, we're not speaking the language that sick people want to talk about. My observation is that it's healthy people who want to talk about dying and sick people who want to talk about living. So I don't talk about a good death, and I don't see that as my job, even though I do think that we are very helpful to people who are dying to be comfortable and dignified and peaceful. I also don't think we're going to make death so good that people are lining up for it. Like, it's just not going to be that good. It's actually pretty lousy. My other challenge with this issue about good death is that it doesn't actually, thinking about how you want to die, doesn't actually tell you about how you should live right now. And the struggles that people have in choosing treatments is not about how to die, but it's really about how to live and how to live well. And whether to come back to the hospital, whether to start TPN, whether they should have a left ventricular assist device placed or enroll in a clinical trial has everything to do with how they're living and their experience of living, not about how they want to die. And people have ideas about where they want to be, and there are implications for that in the treatments that you choose. But I find that we get a lot farther by talking about how you want to live and what's most important to you. So let me give you an example. Betty was 102 years old when I met her. She lived alone in a row house in San Francisco. 2 weeks before I met Betty, she bought a new car that she was driving. And she bought a Prius, and she was really proud that she bought this really, environmentally conscious car. Betty was at home having lunch with her family. And in the middle of lunch, she collapsed at the dining room table. Her family called 911. The paramedics came, brought her to the ER. They didn't know what was going on. She needed to be intubated, so she was on mechanical ventilation because she wasn't breathing. They didn't know what happened, but they did a scan of her head. and found that she'd had a huge bleed, a massive stroke that was not survivable. That's when the palliative care team got called. That's when I met Betty in the neurointensive care unit. And her family was gathered, and I introduced myself, and I asked about Betty, and that's when I learned the story about her car and living alone. And her family said, you know, she really doesn't want to live like this. This is just, she didn't want this. I thought, I get that. Can we just stop the machines and let her die peacefully? And I said, absolutely we can, and we did. What really struck me is, I think Betty's story is kind of the fantasy that most people have about their life. Like, I'd like to live to be 102 by myself, drive myself around, eat lunch, and die, boom, in an instant. That's what people tell me. So many of my patients, like, for my patients, that fantasy is gone. But that is the fantasy. Right? That's as good as it gets. Actually, the one thing people say is, I'd like to die in my sleep. I think, oh, that might be better. You know, unless you're the person who wakes up in the bed next to that person, I think that is a little creepy. That happens, though. Really, it happens more than you think. It's a little weird, but I think for the person who died, very nice experience. What struck me in the room is how much sadness and grief and this sense of loss. Even in the best possible circumstance we can imagine. And it really reminded me of just how sad death is for survivors, not just for the person who's dying, but for their loved ones. And so the goal is not to have a good death. The goal is to live a good life. And we have to think about our role as clinicians and as family members, as loved ones, in helping people live a good life. I want to just read a short excerpt from my book. It's about less than a minute long. A story about my grandmother, my Safta, that really gets to this point. My Safta used to sign birthday cards with the wish that you should live to 120. Because Moses lived 120 years, and a traditional birthday wish is that you should have a long life like Moses, the greatest teacher and leader of the Jewish people. But as she got older, my grandmother changed it just a bit. In Hebrew, she switched just one letter, and the change in meaning was profound. Rather than writing, live to 120, she wrote, live to 100 like 20. Live long and live well. My Safta understood that a good life is even more important than a long life. She lived that saying and declined chemotherapy when she was diagnosed with lung cancer at age 93. Not all of us will live that long, but we can all live the essence of that saying by living well. Now, having said that it's not about the end of life and how you die, I do want you to imagine that for just a moment. So imagine the end of your life. Where are you? Who are you with? What is it like? Okay, how many people had this image in mind? Nobody. 1 in 5 Americans will die in a hospital in a stay that includes time in the ICU. 1 in 5. But we did not notice 20% of the hands go up in this room. So why is that? There are some legitimate reasons that people die in ICUs, like Betty. We didn't know what happened to Betty. Maybe she had something that was treatable or reversible. So she ended up in our ICU. Our job then, when she's not going to recover, is to help her and her family to have a dignified, peaceful, and comfortable end, and that can be done. But more often than not, people end up here because they just haven't thought about it. They haven't talked about what's important to them. They don't have any alternative. And when they get sick, when they get short of breath, when inevitable complications happen, this is where you end up in our healthcare system. And therefore, the importance of talking about what's really going on and asking people what's really important to them about how they want to live their lives, so we can avoid this for people who don't want to end up this way. So the myth is that it's about a good death. The reality is that we need to be thinking about a good life and how we help people, even in the face of serious illness, have as good a life as possible. As I said before, what I tell people is my job is to help you live as well as possible for as long as possible. And I will admit that most of my patients, most people still don't understand what palliative care is. But when I say that, they're like, okay, I think I came to the right place. If that's really your job, I'd like to talk with you. All right, so to wrap up, we think about life after the diagnosis. Palliative care can help you live well and long with serious illness. If you or a loved one has a serious illness, you should request, demand palliative care, and do not take no for an answer. If someone says you're not ready, you just say, actually, I'm ready. Please refer me. Or refer yourself. Talking about what you hope for will encourage and nurture hope. We have to really see what's going on. We have to talk about real hope, true hope, to help nurture and encourage it. And the goal is to live a good life in the face of serious illness. It's challenging and it's sad to have to think about. But our goal really is how can we live well? And the answer is that that can be done if we attend to it and talk about it. I'm going to finish. Okay. So that's my book. Thank you for the kind endorsement for folks. We do have a few copies, and I'm happy to sign them. I wrote this really for the public to try and share information that I know from my years of practice with people with serious illness and their loved ones. And it's everything from the diagnosis all the way through to the end of life, and has a chapter on palliative care and another chapter on hospice care. But it's not all about that. It really is about how to live well. I want to finish, though, by giving you a quiz. Did they tell you you'd get a quiz tonight? They didn't? Okay. I'm going to give you the easiest quiz you've ever taken for two reasons. One, you don't have to write anything down. And two, I'm not going to grade you. So this really is the easiest quiz. I like this quiz because it makes the point about caring. Ultimately, what we want is for people with serious illness to know that they are cared for. And the way we do that is by how we act around them, how we talk about what's important to them, and how we support them. And this makes a nice point about how important that is. And you don't have to say anything or write anything down, just follow along. Name the 5 wealthiest people in the world. Name the last 5 Heisman Trophy winners. Name 10 people who have won the Nobel or Pulitzer Prize. Name the last half dozen Academy Award winners for Best Actor and Actress. Name the last decade's worth of World Series winners. Okay, how'd you do? Terrible, right? But think about it. These are no second-rate achievers. Right? These people are the best in their fields. But the applause dies. Awards tarnish. Achievements are forgotten. So I'm going to ask you, give you another quiz, and we'll see how you do on this one. List a few teachers who aided your journey through school. Name 3 friends who have helped you through difficult times. Name 5 people who have taught you something worthwhile. Think of 5 people who have made you feel appreciated. Name half a dozen heroes whose stories have inspired you. Easier? Sure. The lesson. The people who make a difference in our lives are not the ones with the most money, the most credentials, or the most awards. They're the ones who care. Thank you all very much.
Would you entertain questions?
Absolutely, yeah, happy to. Sure.
I'm going to sneak my notes right
Okay.
here. Thank you.
Happy to take questions, comments? Yes, please.
Do you have any kind of statistical source that you go to when you're advising patients on their choices?
Great question. So do I have a statistical source for advising patients? You know, over the years, I've kind of learned a few things about kind of what to expect in the future just by taking care of people over time. But a lot of times I don't know. And so what I do is I reach out to their doctor and I ask. So I had a patient in clinic just last week with really advanced scleroderma. Scleroderma is a rheumatologic disease. It has many manifestations that make your life very difficult. And this patient also had interstitial lung disease from their scleroderma. So on oxygen, really terrible. And ironically, he said, I hope to live to see my son get married in October. And it's April. I'm like, I don't know. So I wrote to his doctors. And I said, what do you think? And they said, I would be very surprised if he made it. And yet nobody had said, I don't know if they knew what he was living for, but I said, okay, well, at our next visit, we have to have that conversation. So what I find is that often my colleagues are more willing to tell me what they think is going on than they're willing to tell the patient. And it was really interesting to me. I talked to his rheumatologist, who is a wonderful doctor, and he said, oh, thanks for letting me know that. I think I'm going to start some TPN. Because, he's losing a lot of weight. And I think if I give him TPN, he'll make it till October. And I'm like, okay, well, that is a path, which is totally reasonable if you think that will help. But I'm really worried. And let me tell you kind of how we think about it. Maybe have a wedding like next month, and then have another one in October. No harm, no foul. You can have 2 weddings, right? So the short answer is I ask when I don't know. Yeah,
We
please.
have a microphone coming over to you so everybody can hear the question.
All right.
Although your voice seems like it could carry. You may not.
Just might.
I work in an acute care hospital, and we're having this discussion in a hospice agency, not at Fit Republic or at a gym. Our physician, our medical staff really struggle with separating the concept of hospice care and palliative care. And when we try to encourage palliative care consults, oh, we're not there yet. Oh, they're not ready for that. We've got a long way to go yet. There's still so much more that can be done. Do you have any suggestions on how to have that physician discussion around that?
So that's really common. Let me just say this is really common. I still hear it at UCSF now 20 years after we launched our palliative care service. So it's really common. Yeah. So I think your insight about hospice and palliative care and trying to separate the two is important. Hospice does have this sort of prognosis attached to it, and palliative care does not. It's kind of, there's no prognosis. As a palliative care doctor, I know that 70% of the people we see in the hospital actually leave the hospital. So the fact that your patient is not dying, so guess what? 70% of the people we see don't die in the hospital, so that's okay. And then it's really sort of education. This is how we can be helpful. Yes, I know they sound similar, or we think of them as similar, but they're really quite different. Our goal is to help your patients live well and long. Sometimes you can emphasize the symptom management piece of it, because people often want that kind of help, and they might admit that they need that help, even if not near the end. So it's sort of the slow chip away. I don't have like a magic bullet for it. A lot of palliative care teams like to think about, well, if I just had a automatic consult, wouldn't that be great? And I think that could work, actually. It's something we're thinking about. My only worry is that it sometimes will work too good, and then you'll just be swamped with care that's beyond your capacity, and I don't think that's a better solution. But I think bringing people around, and then I think for us in the palliative care field, we really have to practice what we say. And so, when the rheumatologist says, I think the gut's not working well and he's losing weight and I'm afraid he's going to die sooner and I'm going to offer him TPN, I say, that sounds good. Because my goal is the same as yours. I want him to live well and long. And if you think TPN will help that, I'm willing to consider it. I'll talk to him about it, but I'm willing to consider it. And I I want to make sure that I am not being nihilistic or that I think that, comfort is the only path, because there are many paths that people get to choose, and some of them are really helpful to people. I think particularly with immunologic agents and biologic agents and cancer and so on, and it's really hard to predict sometimes. And 90% of people who get a left ventricular assist device, they're alive 1 year later. And these are people who are generally really sick and have a 50% mortality. So I want to practice what I preach so that when I get referrals, my colleagues are confident that I'm supporting their patients in the right way. Yes, please.
I just handed wait for the microphone.
I'm a hospice RN, and I handed a patient today a leaflet that we have here at Community Hospice that defines palliative care, hospice care, and home health. And I thought it really very simply explained, what kind of support you're going to get. And palliative people are very isolated, and I don't think they just realize how much benefit they would have. Like you said, it's all education, but
Yeah.
the better pamphlets out there,
Yeah.
the more pamphlets out there will help.
I think that's really wonderful, really trying to lay it out. And some people really like reading and get a lot of good information that way. And I think having that available is really helpful.
Hi, I'm a case manager at a hospital, and
great.
it surprises me even today, like they were saying earlier, how many times I'll come up to a doctor and I say, "Can I get a palliative consult?" And they'll turn around and tell me, "He's not dying." And I'm like, "Well, no, I want it for pain management, disease management." And the doctors still are, there's only a handful that seems to grasp that need. So we do need more education, for our doctors.
Yes, I completely agree. And, it's education, it's talking to them, it's, education over and over and over. Yeah. Look, when we started our service 20 years ago, we had 112 consults in our first year. And now we have 2 teams, and we saw over 1,000 patients last year. So, culture changes slowly, but it changes, And so if you keep going with it and really explain it and try to, just say a few more things, I think it can be really helpful. And I like the idea of this is for symptom management. What is this for exactly? To really hone in on the reason for the consult, which often will get you just a little bit over the hump. Yeah. In the back.
The medical students at the University of California at San Francisco, did they have any palliative care in their curriculum?
They do now. Yeah, at UCSF they do, yeah. Not when I was a student there, I'll tell you. I was just saying my 30th medical school reunion is coming up next weekend, and we learned nothing about palliative care. I didn't even hear the word when I was in medical school or in my residency training. I didn't, although, I did my medical school training in San Francisco, my residency, during the kind of the peak of the AIDS crisis. And so, we were actually doing palliative care. We didn't have a name for it, but we were doing a lot of it. But now they do. Across the 4 years of the curriculum, they do. I always think they need more. But then every cardiologist thinks they need more cardiology too. So, but yeah, they do. And our elective for 4th year students is actually one of the most highly sought after electives, which is great. One of my colleagues, Sunita Puri, who was a resident with us and was a medical student at UCSF and a resident with us in medicine, just wrote a book called That Good Night, which is really lovely. It's gotten great reviews. She runs what's that?
It's a good book.
Yeah, thank you, yeah. So it's really lovely, and she runs the palliative care service down at USC, but in the first chapter she talks about being disenchanted with medicine and taking our 4th year elective on the palliative care service, and how that kind of re-energized her about medicine. And so the answer, that's a long way of saying yes. Yeah.
Yes, I'm on the board here, and I was
Great.
wondering if you could tell me what the state of the insurance industry and government reimbursement is with regard to palliative care?
You bet. So it gets paid just like any other medical service. So, you know, we see patients and we get paid. Medicare pays us, Medicaid, Medi-Cal will pay us, insurers pay us. The challenge for us is that they only pay for the doctor time, and palliative care really is provided by a team. So, you know, we are nurse, social worker, chaplain. A lot of what happens that's of benefit to patients is happening between visits that is not the care I'm providing, but is the care that the rest of our team is providing. And so while if I got to practice alone, it would mostly work out, the patients wouldn't get the care they need.
So where does that gap come from?
That's a great question. In the hospital, that gap comes from the health system. So from the hospital and the health system, they pick up the gap. And in the outpatient setting, in our system at UCSF, that also comes from the health system. So they employ our nurse, social worker, chaplain. The doctors bill. I think where we're going, though, as the health system moves more towards what we're calling value-based payments, so accountable care organizations, Medicare shared savings programs, and so on, we're moving into a system whereby we're just going to get the money we get for taking care of people, and we're going to have to figure out how to spend that money in the wisest way to get the best care for the most people. And that system of payment really allows you then to think very differently about care. And rather, you know, in that system, people who want to stay home, keeping them home, that's really beneficial. Right now, believe it or not, they're, you know, at UCSF Medical Center, when I say, hey, we did a great job, we kept all these really sick people out of the hospital, they're like, that's not so great. I think, wow, that's interesting. From a bottom line, maybe that's not so great. From a patient perspective, that's really fantastic. And so we need a system that really reflects paying for what is most important to patients. And the challenge is, it's been described as having one foot on the dock and one foot in the canoe. Right? It's a very unstable place, but if where you're going is these kinds of value-based payments, but where you are today is still fee-for-service, you're in a very precarious place. And I think it makes it hard for any agency doing palliative care. The good news is that the state of California actually mandated home-based palliative care for patients with Medi-Cal. And so there is now a payment structure in place that's a different way of paying for people with Medi-Cal. Our hope is that that will extend to all patients. And Blue Shield of California has a plan like that, and others are doing it in HealthNet. So I think we're moving in that direction.
I just wanted to say that I actually worked in a facility that we had a palliative care program that was phenomenal. And I think for the growth, for the staff, that the nurses began to become empowered to make the recommendation. And it was run by nurse practitioners. There was an overseeing physician, but we had nurse practitioners. And I really think that it made a difference. Yes, our patients were kept out of the emergency room, but that was the goal.
Yeah.
And it was a conjunction program with the med-surg floor that I worked on, that we were able to really
That's
teach
great.
our nurses on how to use palliative care. And like I said, to me, it was an eye-awakening. I learned a lot, and I've always felt that it's a worthwhile program. So I hope that we can bring that further out and teach our future nurses, as well as our present, how important this is to have present. So.
Thank you. Thanks for that. Just to comment, undergraduate nursing schools have now mandated palliative care education as part of the curriculum. That happened, I think, 2 years ago. So that's a huge step forward in mandating that. So we're moving in that direction.
One area that we're looking at expanding is expanding the palliative care program into the outpatient setting and into the physician clinic setting, because it feels like all of this should happen way before a visit to the hospital.
Agreed.
So when that patient is in the cardiologist's office after their third emergency department visit, they would have the option to say, you know, we have a palliative care team down the hallway here. I'd like to refer you to them to talk about how we can continue to let you live with your congestive heart failure.
Agreed. Yeah. I think that's where things are moving, really, if you look at it. I mean, a lot of palliative care started in hospitals because the need was so great and the opportunities were so many, but that's exactly the experience. Like, now what? You left the hospital, now what? And so, building that out. So, totally agree. Yes?
So I have had the joy of sitting on our bioethics committee at our hospital, and I noticed that before palliative care came to our hospital, like our bioethics consults were like here, and then palliative care came, and the bioethics consults came down here. So, having those really hard conversations, it's made it more, easier. So I've never been like in the medical staff part of the hospital, with the administrator people, but I just think, it just makes sense to me. Everything that you're saying, I just don't understand why people don't get it. Like, I'm not saying that to be facetious or anything, but the money, the quality of life, the conversations with families to make that, that one-time decision. It's going to be hard anyway, but I just don't understand, like, this makes so much sense to me, and I don't understand why the money is not there. I can see why you said, like, for the residents are wanting to have that kind of experience in their elective, because it makes sense. It's just those conversations are so important to be able to have with people and families.
Thank you. Yeah. That's not, it's an interesting observation about palliative care and ethics consults. My background is in ethics, and that's sort of my path to palliative care, interestingly. And lots of people have a path to ethics to palliative care through ethics. But my observation on the ethics committee was that about maybe more than half the cases were just communication challenges. They weren't really ethical dilemmas, like what's the right thing to do. It's just like people don't agree. And they didn't know where to take it, so they would take it to ethics because we got a problem here. And that good communication and really understanding and facilitating good communication can resolve those. That's it. Thank you for sharing that.
So I'm a social worker at a hospital.
Hey. Yeah. Hey.
I'm just interested in your experience, if you see a difference across either cultural or ethnic groups as far as the referral to or understanding of or engagement with palliative care.
It's a great question. So what about cross-cultural issues? I'm going to say no. I don't. I think we have assumptions about different groups of people, but it is not my experience in caring for people that I can know how someone's going to respond by knowing their background, either their language or their nation of origin or their religion. I can't tell. So, what I teach my students is curiosity. Just bring curiosity and ask questions, because chances are you're going to get it wrong if you make any assumptions about anyone. And there's plenty written about different ethnicities and how they approach things, but I find that unhelpful.
What about resistance? Do you ever get a patient that is resistant? And then what's the workaround? Because in our field, we find that people don't want change. They've been living ill for a while, and they don't want any more interference.
Yeah, some people, I think, when they misunderstand what we're about, don't want it. Some people just don't want another team. They're kind of maxed out. We say, oh, we'll do telemedicine. They're like, yeah, I don't want that. So I think some people do that, but it's either a misunderstanding of what we do, which can often be clarified, or it's that they're almost like too maxed out for help, which is unfortunate, because I think we're really helpful to people, honestly. Again, I was on a telemedicine visit just yesterday in the office, and like halfway through, the family's like, well, we had no idea what to expect, but this is really helpful. And they just like spend 5 minutes crying. I'm like, I don't know how this is going. And then they're like, this is so helpful. I'm like, oh, good. We think so. So it's really, And I will give our nurse, Eve, a lot of credit. You know, she's the person who calls the patient and says, let's schedule an appointment for you, and the referral comes in, and really works with people to explain what it is we do.
Is there one last question?
All right, great.
Well, help me thank Dr. Stephen Z. Pantilat.
Thank you. Thanks a lot.